thank Dr. Flores and his Smile Train for hosting this remarkable event. I received royalties for my book, Cleft Lip and Palate, and also I'm part of the Brazilian Council of the Smile Train. As our prior speakers just mentioned, there are three main techniques: the LaFour-1 with immediate movement, a bimaxillary surgery, and a LaFour-1 with distraction osteogenesis. There are several studies comparing those techniques and showing that distraction osteogenesis has the lowest relapse rate. The indication of maxillary distraction osteogenesis, excessive scarring following cleft palate repair, large movements larger than 10 millimeters, uncertain blood supply, and borderline speech competency. This drawing shows how we use the internal distractor device to advance the maxilla. The upper part of the plate is affixed in the zygomatic body, and the lower part is affixed in the maxilla. And the long axis of the distractors should match that of the osteotomy, and the vectors should be exactly parallel to each other. Dr. McCarthy was the one who pioneered distraction osteogenesis. The NYU protocols requires a 2 months of consolidation period. When I start my career back in 2007, this is a patient from 2007, I used a similar protocol for all types of distraction osteogenesis. But maxillary distractions is a little bit different because we are distracting a shallow bone. Most of the bone ossification happens in the pterygomaxillary junction, which is a little bit different than the other regions of the body. So here is the patient after the LaFour-1 distractions, and here is the cephalograms. And 1 year or 2 years after, we observe a significant relapse rate and collapse of the maxillary arch. So something must be changed to guarantee satisfaction outcomes following maxillary distraction. So the first one is the distraction overcorrection. The overjet should be secured with elastics. And something that we changed, that the maxilla should be affixed with plates and screws to prevent relapse following the maxillary advancement, and always bone grafting first. The criteria is to alignment of the alveolar arch with autogenous bone grafting is of paramount importance. It's always not possible to control two pieces maxilla. And another topic that it is extremely important is to release the soft tissue restriction first. With the lip restriction, which should be addressed with AB flap, and the palate restriction we always address with buccinator flap. I'll show some cases. This is a 13-year-old patient with 13 millimeter of jaw discrepancy, and here is final occlusion after distraction osteogenesis. And here's how we fix the upper and lower plates of the distractors. And here is the cephalogram sequence showing preoperative, during distraction osteogenesis, and after plating the maxilla. We can see a small overjet there that recurs during the follow-up. There is always a small relapse even with we plate the maxilla. And here is a final result and a profile view. And we also address the nose with parietal bone grafts to augment the nasal dorsum and augment the nasal tip. And here is the post-operative view, worm's eye view, and final occlusion after braces removal. This is a very severe patient with a small mandible and borderline speech. This is a perfect indication for maxillary LaFour-1. And here is the patient with a huge discrepancy between upper and lower jaw. And here how we have the distractors parallel to each other, as I previously mentioned. And here is preoperative and during distraction and after fixing the maxilla with plates and screws. And here's with the lip adhesion, nasal repair, and retouch and maxillary advancement. And here's the patient post-operative view and occlusion, worm's eye view. Another example of a huge discrepancy just after the operation. Here's 10 years after the occlusion is stable, no relapse has happened during the follow-up, as can be seen here in this profile. And rhinoplasty was offered but declined by the patient. Here is the final occlusion and with dental prosthesis 10 years after the procedure. And here is a patient with a rare facial cleft and that treated many years ago, 47 years ago. And during the follow-up, it's important really to have a longitudinal follow-up. And at Sobapar, we pay attention on this, having a strong social worker who can call the patient, recruited them to come back and show up again to the clinic. Here is the patient, 30 years of follow-up showing maxillary retrusion. Patient during the follow-up presented a fistula in the Pittsburgh zone 3, transition between the hard and soft palate. And as I previously mentioned, the soft tissue restriction on the palate was treated and addressed with the buccinator flap, which diminished the forces that we require to bring the maxilla forward, as can be seen in this image. And here is the patient prior to LEFOR1 distraction. And here is preoperative, the beginning of the maxillary distraction, and just after completion of the maxillary LEFOR1. And here is the patient with also secondary lip repair. Here is 47 years of follow-up. The patient at birth, just after birth, and at 30 years of age, and here's almost 45 years of age with maxillary LEFOR1. Those are very challenging, complex cases. And here's as another severe bilateral cleft patient that was addressed with maxillary LEFOR1, but as I mentioned, soft tissue restriction should be addressed first, and the palate with buccinator flap, the lip with Abbey flap. And here he had a collapse of the maxillary arch, which was addressed with maxillary expansion by our orthodontic team. And then subsequently to the orthodontic work, we performed an Abbey flap to diminish the forces to bring the maxilla forward. And here is how we place and affixed distractor devices, one parallel to each other. And here is the, after the removal of the distractors, we can see bone on the gap, but this is unusual. Most of the bone is in the pterygomaxillary junction. Now here's the patient cephalograms preoperatively during the initial of the maxillary advancement and after consolidation period with maxilla being fixed with plates and screws. And here is initial result and frontal view, and after 11 years of follow-up. And this is the profile sequence, preoperative, immediate result, and a long-term follow-up. Here, a long-term follow-up, 11 years of follow-up, and with also a fat grafting on the lip. It's important to mention that when we compensate the occlusion, we always end up with a soft tissue and lip imbalance and discrepancy. So surgeons should be aware that we are compensating the occlusion, how we should manage in the future the imbalance of the lip discrepancy that's always a concern for the majority of the patients here, the occlusion. And another late presenting patient, when she had a lip done elsewhere and presented with an open palate, cleft palate, very difficult patient that we performed the cleft palate repair. The patient remained with VPI. Those are adult patients are extremely difficult to deal with, to manage, as I previously described in many of my papers. And here I elongate the palate using the buccinator flap to avoid the forces that can prevent the maxilla to go forward. And here is the final occlusion. We have to have in mind that the maxillary distraction osteogenesis is an intermediate procedure. Then using the internal distractor device, we have always a chance to go back and really put the patients in a stable occlusion. And here is her final view. Thank you again, Dr. Flores, and it's my turn.